designs. And now we have decided to climb the pyramid of evidence and address the basics of a randomized control trial. We are 24 hours away from the WCN 2022 that just concluded yesterday. And for those trainees who could not attend the WCN, there were a couple of sessions dedicated to randomized control trials, wherein newer clinical trials related to nephrology were discussed, like platform trial, umbrella, basket trials, adaptive trials, preclinical trials, and so on. And there was a session yesterday wherein they discussed about the challenges of conducting a randomized control trial in LMICs. The paradox is that LMICs have the least number of RCTs when they actually have the highest burden of various kidney diseases. So today we are taking a very, very tiny step towards addressing this gap. And we have pairs of faculty and residents handling this session in 3 parts. And as Nivedita coined her title of her section, we are going to provide you with a very interesting and important recipe. And she's going to give you some ingredients for the recipe, followed by Dr. Priyamvada would add more to the ingredients and tell you how to use those ingredients. And I would do the easy part of tasting that recipe and giving a feedback. So we 3 faculty are joined by 3 very enthusiastic residents who have volunteered to come onto this platform and discuss an RCT with us. We have been working with individual residents for the last couple of weeks, and they have been very prompt in completing their assignments and working towards making this session meaningful. So let me introduce the residents first. We have Dr. Puranjoy Chakravarti from IPGMER, SSKHM Hospital, Kolkata. He's a DM resident in nephrology. We have Dr. Anamika Das, who is a DM resident from CMC Vellore. And we have Dr. Siddharth Herur, also a DM resident from Nizam's Institute of Medical Sciences, Hyderabad. Dr. Nivedita Kamath doesn't need an introduction to most of you trainees and nephrologists, but it's my pleasure to say that I'm very proud to have her in our department. She's a very accomplished and talented colleague of mine. She's the first DM nephrologist, pediatric nephrologist in India, and she has worked on an RCT study, which was a multi-center study involving 4 centers of South India. So she would start the first session along with Puranjoy, and later we have Dr. Priyamvada, whom I'm sure you all know. You must be having her before you as an examiner too. Besides being the head of nephrology in a very reputed institution like JIPMER, she is very proficient, and I really admire her for her amazing skills related to research, study design, and biostatistics. And I'm very happy that she's joining both of us here for these sessions because her inputs are really going to add more value to these sessions. So thank you so much, Win India, for giving us an opportunity. We will set the ball rolling. Dr. Nivedita, please.
Thank you, ma'am, for those very nice words of introduction. It's always a challenge to live up to the expectations, I guess. So before we start the session, a very small session on firing your neurons and getting everyone ready for this session that's coming up. And so I'll just quickly put a few questions. These are mainly for the residents who have joined us as panelists, all 3 of you, and also if they are unable to answer, the audience. So this is just spot it like spotters in your exams, but this is not an exam, so just relax and think of what you can.
Madam, pardon, but actually your sound is very low. Sound I cannot hear properly.
Is it better now?
Yes, ma'am.
Okay. So it's the main clue is that these are pictures that are related to randomized controlled trials. So let's get the ball rolling with the first easy question.
Yes, this is a
terminology related
blind.
to randomized
Blinded.
control trial.
Yes, blinding.
Yes, absolutely correct. Double blind study. So you can see that both the investigator as well as the subject are blinded. So it's a double blind study. Of course, this terminology is no longer recommended, but this is what is commonly used. This is a central hospital which is attached to several small clinics, and some of these clinics have been selected to be a part of the trial.
Randomization,
Yes, what kind of randomization?
cluster randomization.
Absolutely correct. Cluster randomization. Very good. So the next question is here.
This is also blinding because
I think this is related to placebo.
placebo. Yeah.
Absolutely correct. This is the placebo effect, which means that a part of the well-being or the improvement in symptoms or the state of the patient that you see is due to a placebo effect. And this is your data of the randomized control trial that is ready for final analysis. These are the patients in the treatment arm and these are in the control arm. So what is the principle of this kind of analysis?
Intention to treat.
Absolutely correct. Intention to treat principle. And this is just to check your knowledge of history about randomized controlled trials. So what do you think is the relationship of these citrus fruits? Any history buff?
Nephrologists would think of only potassium looking at this.
So
Fisher and
To the
Radford Hill
treatment
was
of
are vitamin
scurvy.
C supplements that were given to randomly allocated naval soldiers by Dr. James Lind. And this is how he found that vitamin C deficiency causes scurvy. So this is one of the first instances of randomly allocating treatment to human subjects. So that's how the journey of randomization and randomized control trials began. So thank you very much. After this quiz, I'm sure we have to buck up and make sure that, because you already know most of the things that we are going to talk. So let's see if we hope we have more to share and more for you to learn. Thank you. I'll quickly go to my presentation if Dr. Puranjoy is also ready.
Nivedita, you may need to come closer and speak a little louder.
Okay, sure. I'll do that.
Thanks.
Yeah, are my slides visible?
Yes.
Okay, so as we said, let's begin our recipe for randomized controlled trials. And as in any recipe, the first thing is to know and understand your ingredients well. So joining me in this discussion today, we have tried to keep it interactive, where we're going to learn about terminologies, the common terminologies used and what they mean. Joining me in this discussion is Dr. Puranjoy Chakravarti, who's a final year resident from Kolkata. So this article has been sent to all the participants. This is used as a trigger for this entire session, and I will be using this to explain some terminology. This is a randomized controlled trial of rituximab in IgA nephropathy with proteinuria and renal dysfunction. The hypothesis is that rituximab, in addition to standard of care, would reduce proteinuria and progression. The cohort included biopsy-proven IgA within 2 years of diagnosis with proteinuria more than 1 gram per day, stable on ACE and ARBs, and with normal blood pressure and eGFR between 30 and 90. Rituximab was compared to standard therapy. These were the two treatment arms, and the primary outcome measure was the change in proteinuria and the change in eGFR. So the question now is this a relevant question in clinical practice? And why do we choose RCT as a study design? Dr. Puranjoy, would you want to take that?
Yes, madam, because for IgA nephropathy, after using SE and ARB with the maximum tolerated dose, still, if we cannot get the proteinuria down to less than 1 gram, then prognosis-wise, there will be renal function decline. So there is always need to fill this gap when SE-ARB are not good enough. And that's why this trial is trying out rituximab over the standard of care, that is SE-ARB, to see if it can impart additional benefit and get the proteinuria down to less than 1 gram. That's why they have chosen greater than 1 gram. Those with they are already on ACARB, and they want to see how is rituximab working over this.
Absolutely correct. So this is definitely a relevant question. IgA nephropathy being one of the most common causes of chronic kidney disease in adults, one would want to do everything to prevent the progression. So why would you choose RCT as a study design?
That is because a randomized control trial is the gold standard for any intervention trial. It has several advantages, like it can prove a causal relationship. It has a very good internal validity. That is, in between these two groups, if I find a difference, then most probably, if it is statistically significant, it can be interpreted that it is due to the intervention only, because I have selected the groups and also selected the periphery like that. Third, the person who is doing the trial, he is in control of the exposure to the of the participants. And fourth is because we are using randomization, so that is allocation of the study person by chance and removing any sort of bias.
Absolutely right. So just to quickly recapitulate what we already learned in the previous session, there are two types of study designs: observational studies and interventional studies. Observational studies where the researcher is a passive observer and sees what happens to the group or a group and a comparison group. And intervention is where the researcher is actively intervening. So here we are using an intervention in the form of rituximab in addition to standard therapy. So this is an interventional study that we want to do. And also, as Dr. Purunjoy mentioned, we would like to randomly allocate to minimize bias. So this is a hypothesis testing study and interventional study. And in the hierarchy of evidence, definitely randomized controlled trials are just below systematic reviews and clinical practice guidelines, and they are the best form of thing to study causality, to establish causality. And by the method of randomization, one could minimize bias and confounding. The most important prerequisite is that there should be a clinical equipoise. That is, there should be a certain degree of uncertainty about the drug in question, whether it is useful or not, whether there is an established therapy or not. So that should be the basis for using a randomized controlled trial. We know that all drugs go through the several phases of trials. The first one is the phase 1, where safety of the drug is tested in a small group of people. The second is phase 2, where the efficacy and short-term side effects are looked at, again using a slightly larger population. The phase 3 is the most important, where the therapeutic efficacy of the drug is compared with that of standard therapy or a placebo, and this is always a randomized controlled trial. The phase 4 happens in the post-marketing phase to look at long-term side effects and the safety of the drug. Nowadays, even phase 2 trials, some of the researchers prefer to use randomized controlled trials, and there is a new terminology which says early phase 1 or phase 0, which is looking at an exploratory kind of study design, looking at the mechanism of action of drugs. So this is a basic understanding of the different phases through which a new drug goes before and after it is introduced for clinical practice. So based on the hypothesis, what are the types of RCT? Purunjoy, would you like to quickly tell us what are the different types of RCTs?
Yes, randomized control trials can be clinical trials where we are trying out an intervention. There can be field trials. There can be preventive trials, like when we are trying out vaccines. There can be trials which try out an etiological agent. So these are the...
Correct. You're right. There can be different types of trials, and though we commonly associate randomized controlled trials with the use of a drug, it need not always be. As he has already elaborated, it could be used in various situations. But also, depending on your hypothesis, randomized controlled trials can be of 3 different types. A superiority trial, where a new drug or an intervention or a procedure is compared to a placebo or a existing therapy, with the hypothesis that it is better than the previous or the known therapy. The equivalence is when you already have a standard therapy that is working well, but a new drug is gotten with probably a better side effect profile, and you want to show that it is as good as the existing therapy. a non-inferiority trial is used in a situation where there is already an established trial and you want to introduce a new drug, which is definitely not inferior. It may be as good or better than the existing therapy. So in order to do this, we need to establish from the existing literature of either randomized controlled trials or other cohort studies, a non-inferiority margin. The line of no difference means that there is no difference between the two treatment groups, and the minimum effect of interest. So anything that extends from in between the non-inferiority margin and the minimum effect of interest is an equivalence trial. If the 95% confidence interval of the new therapy lies beyond the line of no difference and the line of minimum effect of interest, it is a superiority trial. But if it extends beyond the non-inferiority margin, then it is a non-inferiority trial. So based on what the hypothesis is and what we are trying to do, these are the different types of study designs. Again, to just reiterate this, then here, since this 95% confidence interval in study A is crossing the non-inferiority margin, it is a non-inferiority has been established. Here, since it is going beyond the non-inferiority is not established. In all these three trials, since the 95% confidence interval lies between the two lines, it is an establishment of equivalence. Here, since it crosses the line of minimum interest of effect, it is actually going into the superiority side. So it is not equivalent. Here, the 95% confidence interval in the last study is going beyond the line of true difference and the line of minimum interest of effect, demonstrating superiority. So this is how the different study designs are used. Also, based on how the subjects are randomized and allocated into different groups, you could have a parallel arm study or a crossover study. A parallel arm study is a simple study where subjects are randomized either into the placebo arm or the therapy arm, and they continue to be in the same arm till the completion of the study. Whereas in the crossover, after randomization, they are allocated into the placebo and the drug group for a certain period of time. This is followed by a washout period, and then they cross over to the other arm. The advantage of this is that the patient acts as his own control. So you could use a smaller sample size to get a good power. The disadvantages may be that if the washout period is not carefully chosen, there may be a crossover effect of the drug or placebo or the drug usually into the second phase. Also, if there is loss to follow-up between the phases or mortality, this again causes some confounding. So these are the disadvantages of a crossover trial. A factorial design is an interesting concept where two interventions are studied independently as well as in combination and compared to that of a usual standard care. For example, brushing 3 times a day or chlorhexidine mouthwash twice a day, or a combination of this in comparison with usual care. So again, here using a small sample size, you can study 2 drugs independently as well as in combination. But the major prerequisite here is the drugs should be indicated, both the drugs should be indicated in the condition and the drug should not interact with each other. So coming back to our trigger study, they said that randomization was done centrally by random assignment using pre-filled envelopes. So what are the types of randomization and what is allocation concealment? Do you think it is important?
Yes, the types of randomization can be simple randomization where we can use like a toss of a coin or a dice or a envelope. It can be stratified randomization where specific covariates which might influence accordingly it is randomized. There can be also block randomization. For example, suppose there is, for example, suppose in a trial there are various clinics which are acting as multi-center, and I allot a few of the clinics to have the study arm and few of the other clinics to have the control arm. That kind of can be done. That is a cluster randomization. Block randomization is done to ensure that the number of participants are equal, because there are sometimes it happens that the number of participants, if it's a small study, there can be an equal number and then interpretation of the result will be difficult. For large studies, is not a problem.
Yes, that's correct. So, like we already said, randomization means that all the subjects, that each subject who is being enrolled into this study has an equal chance of being allocated to the treatment group or the control group. And this is purely by chance and is not controlled by either the participant or the investigator. Like Purunjar already said, simple randomization is the simplest and the easiest one. You could toss a coin or use a random number table or a computer generated sequence. The tossing of a coin is generally not preferred because it cannot be audited and you cannot go back and check the records. So computer generated sequence is what is recommended. The disadvantage here is that you get a sequence like this, considering that A and B are two different treatment arms. Now, if the sample size is very small, you could get unequal allocation. Like say, suppose you get 7 in the treatment arm versus only, if your sample size was 10, you get only 3 in the control arm. So you have finished your randomization, but it is unequally allocated. So in order to avoid this, one can use a block randomization. So the block size is generally a multiple of the number of treatment arms. So if we have 2 treatment arms, we make a block of 4, 6, or 8. Generally, smaller block sizes are preferred. So suppose we use a block size of 4, you can see that there are 6 different permutations that can be made. Now, the disadvantage here is that at the end of the block, this randomization becomes predictable. So suppose I'm the investigator, I know the first one has got randomized to arm A, second and third to arm B. So it is obvious that the fourth one is going to get randomized to arm A. So this is not permissible or is not acceptable because it introduces bias. So in order to prevent this, unequal block sizes can be used. So you can use a block of 4, 6, again 4, 6, 6, 4. So the investigator doesn't know what block size it is and cannot predict the next randomization. The advantage is that at the end of one block, you can see that whatever the permutation be, at the end of 4 patients, there is equal allocation to both the arms. Stratified randomization, as you already mentioned, is where there is a important prognostic variable. Say, for example, stages of CKD may alter the effect of a particular drug. So at higher GFR, there may be better response, and at lower GFR, there may be a worse response. So suppose you just use a simple randomization, there may be a significant number of patients with severe CKD or low GFR in your treatment arm, and it may give you a false result. So in order to avoid this, you could stratify them based on the stages of CKD a priori and then randomize each strata into the control and therapy arms. Now, you could use more than one strata. You can use, like, say, for example, age and stage of CKD, or age, gender, and stage of CKD. The problem is if you use too many strata, the number of subjects in each arm becomes very small, and especially if there are loss to follow-up or deaths, then there may be difficulty in the analysis stage. Cluster randomization, we have already discussed that the subject here is not an individual, but a cluster of people in a particular location, either a hospital or a clinic or a village. It could be anything. Say, for example, you want to study the effect of a new deionizer in a RO system, or any machine that removes some endotoxins to a much better extent than your existing system. So you cannot randomize one patient to that and another patient to the standard RO system, right? So you randomize the entire dialysis unit in one hospital to using the new machine, whereas you randomize the other into the control arm. So this is where cluster randomization is useful. Now, as we already mentioned, the randomization sequence is generated by using any of these methods. Once the randomization sequence is generated, the patient has to be allocated to that particular arm. That is also again done by the investigator, but it has to be concealed. That the investigator should not be able to predict which arm the patient is allocated to. So this again introduces bias. So allocation concealment commonly is done by using sequentially numbered sealed opaque envelopes. It could be done by a third party like a pharmacy, or by using IVR or web-based programs. So allocation concealment is an important aspect of randomization. Coming to the next two questions, this was an unblinded trial and an open label trial. So why is blinding important, and what is the role of placebo? So can you quickly tell us, Purunjoy, what you think
Yes.
about blinding?
Blinding is important because to prevent measurement bias, there are three individuals involved in a trial: the person who is getting the drugs, that is the study subject, the person who is conducting the trial, and the person who is interpreting the results. Blinding is done so that none of them get biased towards a particular result that is coming. And various types of blinding is used. If the patient is unaware, it's called a single blinded study. If both the patient and the person who is doing the trial is unaware, then it's a double blind study, and the highest degree is a triple blind trial. Well, even the interpreter who is interpreting the result is also unaware of the study and the control group. The role of the placebo is to enforce this blinding, because placebo is something that is to imitate the intervention agent, so that the person who is taking the study group doesn't feel that anything extra or anything less is given. So that helps in the process of blinding.
Yes, that's absolutely correct. But what I would like to add is that the participant, the investigator, sometimes there may be a different outcome assessor. Suppose your outcome is looking at the improvement on an X-ray or an ultrasound. So there may be a radiologist who is actually doing the assessment of outcome, and the data analyst. Okay, so any of these can be blinded. So the terminologies of single blind, double blind, triple blind are now not recommended. It is important to mention who is it that is blinded. Is it the participant, the investigator, both of them, all of them? So you need to mention in particular who is blinded. So like you said, it reduces the detection and the observer bias. In some situations, like for example, when we are using a drug like rituximab, which is an IV agent, which has to be given over a long period of time, there has to be monitoring, there has to be pre-medication. It may be difficult to blind. It may not always be impossible, but it may be difficult to blind in these situations. If there is a surgical procedure that is being performed as opposed to no surgery or a medical therapy, again, it is very important to blind the participant and the investigator in these situations. So in those situations, at least the outcome assessors, if there is any, and the data analyst should definitely be blinded. Again, if blinding is not possible, standardizing treatment and follow-up protocols, which are the same for both the arms, using objective, reliable outcome measures so that there is no subjectivity, duplicating the assessment of outcome, maybe using two people to assess the outcome, say a histopathology slide, two different pathologists who are blinded can look at it, acknowledging the limitations in a publication. Often there is a confusion between allocation concealment and blinding. So to understand this better, because both are concealed or both are not seen or not known. So after randomization, where the randomization sequence is generated, the allocation or the implementation of randomization should not be known, and that is allocation concealment. So it happens before the allocation. Once the allocation has happened to the treatment or the drug therapy, I mean the treatment or the control arm, then blinding has to be there till the end of the analysis, including the analysis, where if the participant and investigator are not blinded, then the analyst at least has to be blinded. As you mentioned, placebo is a inert substance which looks, feels, tastes, smells like the drug, and it helps to maintain blinding for both the participant and the investigator. But also we have to understand that the response is not just by the mechanism of action of the drug. There is also a placebo effect. It's a psychological feeling of well-being that the patient is taken care of. He's getting a drug, he's getting labs done regularly, medical checkups. All this could cause a placebo effect. The natural course of the disease itself may be responsible, or regression to the mean. The other supportive treatment or care that is provided in the trial. So all these are important components of the response. Some ethical challenges are, excuse me. The Declaration of Helsinki says that every patient who is included in the control group should be assured of the best proven diagnostic and therapeutic methods. So if there is an existing standard therapy, then depriving the control arm of this is not ethical. Also, it violates the concept of clinical equipoise, and the use in vulnerable groups who cannot consent, say for example children, is also sometimes ethically challenging. So what does the control arm actually get? They could get a placebo. We have already discussed that. There could be no treatment. But again, that doesn't allow us to blind. Active standard treatment, which is the recommended course, and sometimes you could use a dose comparison as well. Now coming back to our study, the primary outcome measure here was change in proteinuria and eGFR. So what are the prerequisites for a primary outcome measure?
Yes, the prerequisite is that before the start of the study, the primary outcome has to be defined well before the start of the study. And sometimes there are certain trials where if the primary outcome is achieved in a particular difference, in a statistically significant difference, then there is no need to further continue the study, because if the primary outcome gives benefit to the study group, then it will be unethical to deprive the control group of that effect. So in big studies, like the recent studies that are going on, they call off the adjudicator board, they can call off the trial saying that they have achieved.
Absolutely. So this is it could be a single or multiple most important outcome of the study. So what is it that you're doing the study for? The primary outcome in the analysis is the dependent variable. It should always align with the study objective. And as you mentioned, it should be defined at the time of the study design and not after the study has begun, or at the time of analysis, or sometimes even after the analysis has been done. And this is the basis for the sample size estimation. So you have to consider the primary outcome for calculating the sample size. Now, the primary outcome measure is not just the primary outcome variable, but also the time of measurement, the method of assessment, the covariates, and the sample. That is, are you going to take it on an intention to treat or a per protocol analysis? Secondary outcome measures are also important measures for the use of the drug in clinical practice. They may support the primary outcome. Like here, though it is the change in GFR and proteinuria, but we would also like to look at the toxicity, the safety of the drug before we use it in clinical practice. So these are important secondary outcome measures. They also have to be decided a priori. Composite endpoint is used when a single endpoint doesn't clearly define the outcome, or it is a rare single endpoint. For example, mortality. So suppose we are doing a study on, say, a new intervention in AKI. Mortality may not be very common, or you may need very large numbers to achieve that primary outcome, or a significant difference in the primary outcome. So you could use combinations. And so not just mortality is important, but probably the number of days of dialysis is important, or the number of days of hospitalization is important. So all these could be combined to have a composite endpoint. What is intention to treat and per protocol? I think I'll directly go to it because we have already discussed this in the quiz. So inaccurate analysis of data introduces bias. Intention to treat is a very simple concept where all the patients who have been randomized have to be analyzed as they have been allocated to the arm. So whoever has been in the treatment arm, irrespective of whether they have completed the protocol, they have died, they have defaulted, have to be considered in the treatment arm. This gives us a very practical real life scenario, because if you, unlike a randomized control trial, a real life scenario is not so tightly regulated. There are patients who default, there are patients who die, there are patients who are lost to follow up. So what happens in a real life scenario is probably reflected in an intention to treat study. For a superiority trial, like we discussed, an intention to treat is always a must. Suppose we do a trial where the subjects, only those who have completed the treatment as they were originally allocated are included. That is called a per protocol analysis. For a non-inferiority trial, both the intention to treat and the per protocol analysis should be performed. So this we have already discussed is the intention to treat, and this is the per protocol analysis, where only those who have completed the protocol are included in the final analysis. So this again is for all the residents to quickly match the following and summarize this introductory session. So Purunjay, do you want to start? Randomization?
Yes. Randomization is reduces measurement bias.
No, among
sorry.
the options given on the right side.
Oh, reduces selection bias.
Okay, that's correct. It reduces selection bias is correct, but here I put that for something else. It ensures that subjects in both the arms are comparable. Okay. Allocation concealment
reduces selection bias.
Blinding
reduces measurement bias.
Correct. Factorial study design.
Combination of drugs.
Correct. Intention to treat.
Last value carried forward.
Absolutely right. So thank you very much. I hope you enjoyed this session. Thank you.
Wonderful, wonderful, Dr. Puranjay and Nivedita. We'll go to the next session by Dr. Priyamvada and Anamika.
So good afternoon, everyone. So me and Anamika are trying to design an RCT to address the question whether rituximab will work in IgA nephropathy. So Anamika, how would you like to proceed with the study design, assuming that you are the principal investigator?
Firstly, I'd like to have a research question. So in this case, what will be my research question? Like if I have to design a trial with rituximab in question in IgA nephropathy, so my research question will be, does treatment with rituximab in IgA nephropathy have a benefit as compared to standard therapy? Now, why is this my research question? Firstly, my research question should be a relevant one as in context to the current clinical scenario. So in IgA nephropathy, as we all know, it is a very common disease and a very common cause of frustration to the clinician in respect to response to therapy. Very few standard therapies are available, of which, as we have discussed, ACE inhibitors and ARBs are one of the proven treatment measures. But in spite of adequate treatment, still there is a high incidence of progression to end-stage kidney disease. So, being a disease mediated by the IgA antibody, we expect that immunosuppressive measures may have a role in its control. So, on the basis of this background, I would like to design a trial with in which rituximab as an agent which depletes B cells can be studied in as a probable therapeutic measure for IgA nephropathy. So my research question will be whether rituximab in IgA nephropathy has a benefit as compared to standard therapy.
Okay. So can you go to the next slides, because like switching between, can you just tell me how you would like to proceed further?
Firstly, once I've decided my research question, I would like to decide upon who will be my study population and what will be my inclusion and exclusion criteria to include in my study. And also I'd like to decide. I'll also like to decide what will be the aim of my study and what will be my endpoints. So firstly, whom will I include in my study? Definitely, it is a study based on IgA nephropathy patients. So I will be including patients who are biopsy-proven IgA nephropathy, and I will include those who have a chance of disease progression. That is, I will include patients who have a chance of progression, who have proteinuria of at least more than 1 gram per day. 1 gram per 24 hours. And I would like to include patients who have an EGFR of at least more than 30 ml per minute, as we know that less than 30 ml per minute has a very poor prognosis. So I'll be trying to target patients who are still within the treatment range. I'd exclude patients who have a lesser EGFR than 30 ml per minute, and patients who have who have received prior therapy with immunosuppressant agents, as they may lead to confounding findings in my study. Now, what will be the endpoints of my study? I'd like to discuss upon that. So, what do I want to achieve with treatment in IgA nephropathy? My basic aim of treatment will be to achieve remission in proteinuria and to slow down or retard the progression of the disease. So, my primary endpoints, that is the main result, which should be measured at the end of the study to see whether my treatment, that is whether rituximab given as the treatment is working or not. So I'd like to assess for proteinuria at the end of my study period, and the progression to end-stage kidney disease or the rise in serum creatinine from baseline or EGFR. So these will be my primary endpoints. Now, in my study, I can also think of several other secondary endpoints which may help in uh, benefiting my study. These may include adverse events detected during the study, levels of serum IgA in the intervention versus the control group, so as to assess whether rituximab has an impact or not on the level of IgA, which is responsible for the uh, uh, disease entity. Also on the safety of the uh, treatment drug, and whether it has any impact in quality of life of the participants. So these are endpoints which are not very subjective, but which are not very objective, but can help in uh, uh, increasing the value of my trial drug. So I would like to include those in my secondary endpoints.
Thank you, Anamika. I'll come back to you later. Now I take over. Can you stop sharing your screen?
Yes, ma'am, sure.
So is my screen visible?
Yes, ma'am.
Yes, yes.
So basically, all these things has been already discussed by Nivedita. Now, what is the clinical equipoise in IgA nephropathy? We know that the only treatment with level 1 evidence is AC inhibitor or ARB, whereas steroids, the evidence is pretty low, it's level 2B. And you need to be very careful, especially if you are giving corticosteroids in people with GFR towards the lower side. And the rest of the other things, whether it's a safe drug, whether it's ethical, and whether the outcome can occur over a reasonable time period and the disease is common enough to be addressed by RCT, we all know the answer. So obviously, there is a clinical equipoise and you have a drug which has been found to be effective in many glomerular diseases, and possibly if this proves to be effective in IgA nephropathy, possibly it is going to add to our therapeutic armamentarium. Now, these are the broad topics under which I'm going to discuss over the next, say, 25 or 30 minutes. The research question framing, which already has been dealt in the previous session, and I'll be discussing a little bit detail in the real life endpoint, which we should select in a study with IgA nephropathy and rituximab, and a little bit about the inclusion and exclusion criteria, then details about the sample size calculation. Randomization mostly has been dealt with Nivedita. So I'll be just discussing a few aspects which you need to be careful doing the randomization. Allocation, containment, and blinding already discussed. And finally, I'll be discussing on how to conduct the study and how to ascertain the outcomes. So Anamika has come up with a research question, but whenever we put a research question, it's always better to put rituximab, like the research question in the PICO format. So here the population is IgA nephropathy. Maybe you can fine tune or finally write it as people with IgA nephropathy with so and so GFR and so amount of proteinuria. Intervention is rituximab. The control arm should receive the standard of care or the active agent, which obviously is not going to be there in this study because we know that corticosteroids are not going to be of that great use. And the outcome could be proteinuria, GFR, or a combination of both. And you have to take a reasonable time frame. How much time rituximab would take to reduce the proteinuria? So for example, if it's proteinuria, anytime from 3 to 6 months is fine. Whereas if you want to see what is the impact of GFR, possibly you will have to go for a slightly longer time frame. Now the study endpoints. So basically, I'm not going into the details of how to select the primary endpoints. The primary endpoints which we could select in a study with rituximab is one is changes in proteinuria. You can either define it as a proportion of people who attain complete remission, but there is a small problem with that. We know that unlike diseases like membranous nephropathy or lupus nephritis, the proportion of patients who completely remit the proteinuria is going to be less. So putting the primary objective as people who attain complete remission, possibly there is a chance that we might not actually get sufficient people to reach the endpoints. So it might be better to take the changes in proteinuria. You can change the absolute changes in proteinuria, or you can change the proportional changes in proteinuria. Now you can select the changes in the glomerular filtration rate. It all depends upon what you decide to include. Suppose you are including patients with the proteinuria and GFR maybe somewhere in the 60 to 90 range, we know that these people are at slightly lesser risk for progression to CKD. So in that situation, probably the absolute changes in GFR could be the primary endpoint. And on the other hand, if we are recruiting patients with more lower GFR, let us say more towards the 30 ml range and all, then possibly if the study duration is sufficient enough, we can even actually keep the primary endpoint as a reduction, 50% reduction in the GFR over passing over to ESRD. It all depends on whom you select and how much time you have at hand. So there are no hard and fast rules on how many endpoints you need to select, but if possible, limit to one. Because more than one endpoint, usually there might be problems with the multiplicity. And another thing is, let us say, if I am taking a GFR-based criteria as primary endpoint and a proteinuria-based criteria, then both should attain statistical significance to tell that the rituximab will work in IgA nephropathy. Now, let us assume that I had taken two endpoints, one proteinuria-based endpoints, and the other one was a GFR-based endpoint. Let us say this is the situation, the absolute GFR, there's not much of a difference. And the 50% reduction in GFR, again, I had taken it as a primary endpoint. There's not much of difference, but there is a significant difference in proteinuria with rituximab. Now, if I had taken this 2 or 3 as my primary endpoints, I cannot say that rituximab works by just looking into this reduction in proteinuria. And if I have to say that this drug works and this can be used further for clinical cure of patients, since I had selected 2 primary endpoints, I have to meet that 2 primary endpoints. And obviously, we know from the steroid experience that a simple reduction in proteinuria without GFR protection over a sufficient period of time probably doesn't really convey any clinical relevance to the patient. Now, as Anamika said, you can have any number of secondary endpoints because whatever you cannot put as the primary endpoints, but whatever you would like to get information from the trial, you can put as a secondary endpoint because only your primary endpoint is linked with the sample size. Now, I have a question for Anamika. Can we select a composite endpoint? So let us say if I want to select a composite endpoint of ESRD, death, transplant, and a 50% reduction in GFR, which looks pretty meaningful, is it possible?
It is definitely possible, I feel, ma'am. But probably the study duration will have to be longer if we take it as a composite endpoint.
Yeah, it all depends upon, as I told you, it all depends upon whom you select and how long you want to conduct the study. For example, I am limiting the study to people with the GFR between 30 to 60 ml. Then if I have around 3 to 5 years ahead of me, I know that a good proportion of patients might reach any of these targets. But on the other hand, if I'm recruiting patients from 90 ml to 60 ml or 90 ml to 45 ml with proteinuria, I know for sure that these patients might reach this, but it might take a longer period of time. So for example, if I select people who have the upper range of GFR and if I'm planning to finish off the study at 1 year, it's almost certain I won't attain any of these endpoints. So a composite endpoint is still feasible, but probably in patients with advanced disease, and you should have a decent study duration. Now, coming to the inclusion criteria. So all these things Nivedita has already discussed. Now, these are the factors which we want to consider while recruiting a patient for IgA nephropathy. So obviously, this should be biopsy-proven cases of IgA nephropathy. Now, the question is, when this biopsy would have been done? So it is possible that the biopsy would have been done in the patient's teenagers when the patient started having microhematuria and proteinuria, and now the patient is 40 years old, whether such a patient can be recruited. Okay, so here again, all these things are decided. What is your primary objective and how much time you are having? For example, your primary objective is attained and you want to include patients with a reasonably, maybe let us say, for example, let us take, you want to include patients from 30 to 60 ml. So you know that these patients are likely to progress faster and they may have a significant component of mesangial tubular atrophy and sclerosis. And if you select such type of patients, it is always put a rider that they should have a recent biopsy. It is again up to the investigator. It could be 6 months. But the problem is if you keep it as 6 months, we may not end up getting patients. So maybe you can extend it to 1 year or 2 years, but it should not be too far away, because the biopsy, there might not be any sclerosis or anything to begin with. But now many years have passed and the patient is having a marginally low GFR. So obviously what is there in the biopsy is not likely to represent the situation as of now. And similarly, proteinuria. So nowadays, like if you select patients with a lesser amount of proteinuria, let us say 500 milligram, then there is a possibility that they won't even progress at all. So basically you have to define the proteinuria, and almost all standard recommendations, the proteinuria cutoff for progression is more than 1 gram. So it is always imperative that you should stick on to that criteria. Now there comes another question, how much should be the upper limit of proteinuria? And we know that even though uncommon, IgA nephropathy can sometimes present like a minimal change disease-like presentation. So when you are defining proteinuria, either you put an upper cutoff, or if you're ready to take patients with more than 3.5 gram, then ensure that you don't end up selecting patients who have the nephrotic syndrome-like presentation. And again, glomerular filtration rate, what is to be the upper glomerular filtration rate and what is to be the lower glomerular filtration rate depends on your time period. If you want to see the GFR reductions, you have only 1 year at hand, then possibly you will have to end up selecting patients who are having GFR towards the lower end of the spectrum. And now MES classification is universally accepted as a prognostic marker. So maybe you can either include MES classification in the variable or MES classification in the inclusion criteria, or if that is not possible, you can include it as a stratification variable also. And you have to ensure that the patient is on optimal RAS blockade. And now from our DAPA-CKD trials and all, we have shown that we know that SGLT2 inhibitors can actually be used in IgA nephropathy. So probably in the coming years, SGLT2 inhibition is also going to come up. So maybe in future, when you are planning studies on IgA nephropathy, you should decide whether you should stick on to people who is on optimal RAS blockade, or whether you are going to include patients with SGLT2 inhibition and all. And again, since SGLT2 inhibitors are not that widely used as of now, but the scenario is likely to change in the coming years. So possibly it is better that you have a clear idea whether to include or whether not to include, because sometimes that can be a confounding variable. And obviously, steroids and immunosuppressants, it's again up to the investigator to decide whether to include patients who had already received steroids and immunosuppressants. If the investigator doesn't want to include, fine. And if the investigator wants to include, that's also fine. But the only thing which you need to ensure is sufficient time has lapsed between the steroid and immunosuppressant therapy. Now, I would just like to mention about something called a run-in period, which is often seen in randomized controlled trials. It is sometimes called a washout period when you stop a drug. For example, you want to study the effect of an antihypertensive or a proteinuria reduction drug, then possibly you will stop it for a temporary period, then probably you will restart. And the importance of this run-in period is you identify the patients who can be recruited to the study. Then probably you put them on a placebo run-in period, or maybe in rare situations, mostly not in nephrology, you may put them on an active drug also. And basically the idea is to screen for the non-responders and non-compliant population, because a good majority of the loss of follow-up happens in the initial few months of the study, and mostly within 1 or 2 months. Now, if you ensure that that much run-in period is there, the likely non-responders, or more important is the non-compliant people, can be excluded. And this, since actually you are doing this prior to randomization, this may not introduce a major bias. Now, there is something else called enriched enrollment. I couldn't think of a situation where we can use an enriched enrollment in IgA nephropathy. So I'm just going back here. For example, you want to see whether early versus late initiation of dialysis is better in acute kidney injury. Now, we know that not all patients, even with the AKI3, need not have dialysis. So basically, what you do is you can use a biomarker, or you can use a test like furosemide stress test. And those who does not respond or those who have this biomarker positivity can be randomized. So basically, this run-in period, enriched enrollment, everything are techniques which are used to improve the yield of your study. Now, Anamika, what should the control arm receive? Should they receive a placebo or not?
Yes, ma'am, I feel they should receive a placebo to reduce the bias from the end of the clinician as well as the patient.
Yeah. Yes, if possible, it is okay. Already Nivedita has covered, so I am not discussing here. So basically, if possible, in all randomized control trials, the control arm should receive a placebo, because if you give the drug, you'll see an effect like this, but that effect itself is composed of many things, which include the drug effect and many other additional effects. Now, if we does not give a placebo, we might end up thinking that this entire effect seen is because of the drug, whereas actually this is the only part which is contributed by the drug, and these are other things which would have happened even when the drug was not there. So if possible, you try giving a placebo. And the control arm should always receive the standard of care, whatever be the situation. The patient has the right to receive the standard of care, and sometimes very rare fatal diseases, it is unethical to deprive treatment to the control arm. So in such a situation, there is something called a synthetic or external control arm. You rely on historical data. So this is also coming up in a big way, especially for uncommon diseases, and possibly I don't really think that we have come across any recent trials in nephrology, including synthetic or external control arms, but yes, that is also coming up. There are actually techniques to minimize the bias and all. Now, Anamika, which trial design will you employ? Superiority trial or a non-inferiority trial?
Ma'am, I'd like to employ a superiority design trial. The basic reason will be the standard of care in IgA nephropathy is already defined with ACIs and ARBs. So basically, whatever drug I want to try right now, my aim will be that it should be better than the standard care, because as of now, the standard care is yet to provide very beneficial effects in this group of patients. So I'd like to employ a superiority design trial. Also, another reason is because I want to compare it to a placebo. When we use a placebo control trial, a superiority design is mandatory.
So yes, I don't know, my slides have stopped moving. Okay, so always go for a superiority design when the drug does not really have a definitive therapy, as in IgA nephropathy. We know that the only level 1 evidence is on RAS blockade. So invariably, every patient with IgA nephropathy with proteinuria is likely to be on optimal doses of RAS blockade. And now you want to know whether adding rituximab is going to give any extra benefit over the standard of care. And sometimes you can actually use it as an add-on treatment. For example, there might be diseases which is not at all treatable. Okay, so then whatever existing standard, it might not be a definitive drug or anything. The control group should receive that, and the intervention group should receive the new drug which we are testing. So in case of IgA nephropathy, the standard of care is ACE inhibitors and ARB. So every patient in the both arms should receive ACE inhibitor and ARB, and the intervention group will receive rituximab in addition to the ACE inhibitor ARB. And here we are going to prove that whatever new drug you are adding, that is producing a better effect than the standard of care. And the effect size should be over and above the effect size of standard of care, effect of standard of care, and the confidence interval also should be in this range. Now, when will we use a non-inferiority design with rituximab? Let us assume that, okay, steroids had a little more better role in the management of IgA nephropathy. And let us say by another 5 years, more trials will come. And probably the indication of corticosteroids gets elevated to level 1B or so. But we know that whatever steroid protocols are pretty toxic. You're going to infuse steroids, or you are going to give high dose oral steroids for around 6 months. And probably that 6 months, especially in adult populations, middle-aged people, the adverse effect profile might not be any great. So in such cases, probably people start using rituximab as like without in outside the trial setting. You have sufficient retrospective data telling that, okay, rituximab brings about a remission in proteinuria. In such a situation, you can compare rituximab with the existing standard of care. Let us say it is drug X or corticosteroid or whatever it is, but it is actually a drug with quite a lot of adverse effect profile. Let us say it brings about remission in 90%, but at the same time, it creates diabetes in 30% or 40%. It might cause bone disease in quite a lot. In such a situation, even if you are trying a new drug, even if the effect is not really 90%, it is somewhere close to 90%, but little bit lower, but it has a really safe margin. The safety profile is pretty good. Then possibly that is the setting for a non-inferiority trial. And you select a non-inferiority margin, and your effect size and the confidence intervals should lie between that non-inferiority margin. So this non-inferiority margin can be obtained from pre-existing studies or probably expert of opinion or probably as a consensus decision. Now, moving on to the sample size calculation. So, Anamika, if you want to, let us say your GFR is, your primary endpoint is a GFR difference. So how much difference will you keep between the intervention and the control arms? Or how much difference in GFR you think is appropriate for a sample size calculation?
Actually, ma'am, what I understand is in the baseline, there should not be a significant difference between the control and.
Yeah, there should not be a significant difference at baseline because that will be taken care of by randomization. But now let us say as a clinician, you are planning to give rituximab to a patient. And to begin with, let us assume that the patient's GFR was 60 ml. Now at the end of 1 year, how much GFR should be okay for you? Let us say at the end of 1 year, if the patient comes with a 50 ml of GFR, is that fine for you?
Yes, that will be fine depending upon his proteinuria.
Okay, so see, basically, you have to go for a achievable and like something which actually would make a change to the patient. For example, you give rituximab, and is there any point in demonstrating that there is only a 1 ml difference between the standard of care and the rituximab arm?
No.
Obviously, nothing will be there. So I'm not actually giving a target difference here. So we know that it's a proteinuric disease, and probably you are likely to lose around, say, 5 to 6 ml or maybe even more over a year. If I can reduce that 5 to 6 ml loss to a 3 ml difference, perhaps I will be happy. And the next factor which you need to consider is a type 1 error. Type 1 error is actually the false positives. And type 1 error is going to be a major problem because you are falsely concluding that the drug is effective, whereas actually it does not work. And you might end up exposing a lot of patients to this unnecessary drug. So type 1 error usually is kept at 5%. And type 2 error is, on the other hand, is false negative. You will reject a drug when actually it is efficient. And type 2 error is of a less serious problem. So type 2 error usually for studies is kept between 0.2 to 0.1. You cannot keep it more than 0.2. And if you subtract the type 2 error from 1, the figure you're going to get is called the power of the study. So basically the alpha error, maximum 5% is possible. You can keep it 1% also. And the type 2 error is 0.2 usually, or in other words, the power is 80%. If you wish, you can keep it as 90% or 95%. But if you keep a small type 1 error and a small type 2 error, that will lead to significant escalations in sample size. And again, your sample size depends on the superiority design or non-inferiority design. Practically, clinical specialties do an equivalent studies that is mostly used in drug development and mostly done in pharmacology and all. Then the other factors which are taken to be consideration is allocation ratio. Usually we have a tendency to allocate 1:1, But sometimes if we allocate 2:1, like 2 patient gets the intervention and 1 patient receives the standard of care, sometimes patient recruitment is going to be much more easier. More patients will be willing to get into those trials. And usually in the real world, dropouts happen. So you should make allowances for the dropouts as well as the crossovers. Sometimes certain drugs, probably you will have to give the intervention if certain criteria are met. So that allowance of crossovers also should be made in the sample size calculation. Now, basically, these are things, again, these are probably things which go into your primary endpoint also. This was something which I was telling, difference in proteinuria or GFR between the two arms. The treating investigator has to decide how much is a reasonable difference in proteinuria and how much is a reasonable difference between the intervention and the control arm. Or you can even use the proportion of patients who attain a predefined proteinuria or GFR cutoff, depending on the study duration and the type of patients you recruit into your trial. So I think this part we can skip. Okay. So you can either use absolute change or relative change. It is based on the investigator's choice and the disease biology and the stage of the disease which you are going to deal with. And coming, this is actually a lot of statistical softwares are available for sample size calculations. So here, if you can see, I have selected the significance as 5% or alpha error as 5%, power as 80%. And I have, okay, this is actually something which is unattainable, a 10 ml difference. I don't really think whatever intervention we give will bring a 10 ml difference, but just for calculation sake, I have put it like that. And the standard deviation of the outcome, I have put it as 5. And to demonstrate this, I need only 8 patients, 4 in both arms. But we know that such a situation seldom happens. Okay. So this is actually a chart to show how things change when you change the difference between the two arms, when you change the alpha and the power. Let us say the first one, 55 ml, I just wanted to demonstrate that there's a 5 ml difference between rituximab and standard of care. With a standard difference of 4, I need to recruit 22 patients. Here, I have not changed anything, but the standard deviation, I have made it 5. Now the number has gone up to 32. Here, I just want to demonstrate a 2 ml difference with the same standard deviation of 5. The sample has become 198 and an alpha of 5% and a power of 80%. Now, if for the same thing, I change the power to 90%, I need to recruit 264 patients. Now, at a 90% power, at an alpha error of 1%, I have to recruit 374 patients. To demonstrate a 20% difference in a categorical variable, that's a 30% decline in GFR again, I need 182 patients as an alpha error of 5% and a beta of 8 and a power of 80%. Now, if I change the power from 80% to 90%, all the other parameters are becoming same. I have to recruit 242. So now you can see that the smaller the target difference, the greater will be the sample size. Your standard deviation is greater, then your sample size tends to be greater. And the lower the alpha error, you need a huge sample size, and a higher power also calls for a huge sample size. Now, what type of randomization will you do, Anamika?
I'd prefer to do a simple randomization, ma'am, for this study.
Okay. Yeah, simple randomization is fine, but you should be careful with simple randomization while you are doing with small numbers. Because simple randomization, let us say, if you are recruiting 1,000, 10,000 or like that, which happens in many of the ICU trials and cardiovascular disease trials, fine, you will end up eventually having somewhat equal number of participants in both arms. But if you are recruiting 30 or 40, it is possible that one arm will have a higher number. The imbalance tend to be higher with smaller numbers. So if you end up recruiting smaller numbers, as it happens in most of the nephrology trials, a better way of doing is a block randomization. And again, the block randomization also will have some problems. Let us say I have used a block randomization, and my idea was I had 12 patients. I wanted to allocate them into rituximab and standard of care arm. So it is assumed that randomization takes care of all the imbalances at the baseline. But still, sometimes the key prognostic variable, let us say MES score. So if the patient in treatment A, the MES score more than 2 is 1, and on the other hand, 50% of the patients, of the 6 patients, 3 out of 6 has a MES score of more than 2. Now we know that MES score is a key prognostic variable and which can actually affect the final GFR or proteinuria. So this is a problem with the block randomization, even though you end up allocating equal number of patients, sometimes the key prognostic variable can be unequally distributed. For example, proteinuria. Let us say more patients in the treatment, one treatment arm had proteinuria. And as you know, proteinuria is something which can actually affect the GFR. Then probably that's going to put you in a little bit of difficult situation. So basically, in addition, block randomization, especially when smaller numbers are involved, and if you think that there are key prognostic variables which are likely to be distributed in a non-balanced fashion, you can go for stratified randomization. And let us say the same 12 patients, and there are 4 people. I'm just taking urine protein creatinine ratio. So let us say those who are blue, they have a PCR of more than 3.5. And the orange circles had a protein creatinine ratio of less than 3.5. Now I have put one strata, PC ratio less than 3.5 and more than 3.5. So this is how it happens. First, the system will divide these patients into those with nephrotic range proteinuria and non-nephrotic proteinuria. And of this 4 with the proteinuria more than 3.5, they will be equally divided into treatment A and B. Similarly, the 6 people with proteinuria less than 3.5 gram again will be equally divided. But as Nivedita told, there is a major problem. You just cannot keep on increasing the strata. So normally, at least 15 to 20 patients, one strata is permissible, but not more than that. Okay. Now the problem is, let us say I have 12 patients and I'm trying to introduce 2 strata. So let us say my strata are MESCOR and this proteinuria. Okay. Now, let us say the blue people will all have MESCOR more than 2 and the greens have MESCOR more than 2. In addition, they have a high range of proteinuria also. So now I divide this. So this is 4 people with the MESCOR more than 2 and I have 6 people with the MESCOR less than 2. Now of this 4 people with MESCOR more than 2, again I am putting another strata, proteinuria more than 3.5. Those blue has proteinuria more than 3.5 and this, let us say this patient has a proteinuria less than 3.5. Similarly, another strata is created here. So eventually what happens is, when I do the randomization, it will be like this. You have 6 people in one strata. Sorry. You have 7 people in one strata and actually the number of people in the other strata is going to be practically less. So this is a problem when you introduce too much of a strata. This has already been dealt by Nivedita and all these things has been dealt by Nivedita. The problem is an open label trial. A lot of bias can creep in, which Arpana madam will be discussing later in her discussion. Now coming to the study duration and follow-up. So study duration is decided by the type of people who include, the resources you are having, and what is your primary endpoint. And there will be issues in follow-up, and most of the time, the most common issue is non-compliance. The maximum loss of follow-up usually happens in the initial 2 to 3 months, and subsequent months, the follow-up is going to be much less. Then there might be treatment switching between the intervention and the control arms. And sometimes loss of follow-up also will happen. Then sometimes death and other events can happen, which would actually truncate the follow-up. So to deal with this loss of follow-up, non-compliance and all, probably you can have a run-in period or you can have adjustments in the sample size. Now coming to analyzing the result. Anamika, what sort of analysis will you do? An intention to treat analysis or a per protocol analysis?
Ma'am, I'd like to do an intention to treat analysis.
Superiority study design should always include an intention to treat analysis. You can do a per protocol analysis later, but your results are incomplete without an intention to treat analysis. Now, why you should do an intention to treat analysis in a superiority trial? So just a small study, 10 patients in each arm, treatment A and treatment B. And okay, those who received treatment A, 7 responded, 3 did not respond. Treatment B, 6 responded, 4 did not respond. Now, so 70% efficacy of drug A, 60% efficacy of drug B, the effect size is 10%. Now, the same chart is repopulated with a little bit of loss of follow-up. I'm taking 1 yes from treatment A and 1 no from treatment A. So people who should have responded, one patient who should have responded and one patient who should not have responded accidentally has been lost to follow-up. Now you have 8 in each. Now if you calculate the effect size, that is going to be 75% versus 62.5%. So the effect size is actually 12.5. So in a superiority trial, if you do this per protocol analysis alone, you're going to inflate the effect size. What you want is a little more conservative estimate. On the other hand, in a non-inferiority trial, you have to do a per protocol analysis. If a superiority trial, you just report the intention to treat analysis, that is perfectly fine. You don't expect the per protocol analysis to be included. If you include, fine, but that doesn't really change much. On the other hand, if it's a superiority trial, you cannot just include only a per protocol analysis. Now, what will happen if the patient has been randomized, but then suddenly patient had a change of mind and patient told that, okay, I don't want any drug. And there is something called a modified intention to treat analysis where patients who are randomized, but who were dead or who dropped out even before receiving the first intervention, you can exclude them, but the problem is this is going to introduce a little bit of bias because every exclusion after randomization will increase the bias. Okay, this is the same thing which I had already discussed. Now, what are the statistical tests used to compare? Most of the time, the statistical testing is going to be straightforward. If your primary outcome is expressed in mean and standard deviation, you can use a t-test if it is 2 group, or you can use an ANOVA if it is 3 groups. And if it is expressed as a median with the interquartile range, you can use a non-parametric test like Mann-Whitney U-test for 2 groups and a Kruskal-Wallis test if there are more than 2 groups. If it's a frequency or percentage or it's an ordinal data, you can again use a Mann-Whitney U-test or a Kruskal-Wallis test depending on the number of groups. If it's a frequency or percentage, a binary data, you can use a chi-square or Fisher's test, or you can express it as risk ratios. Now, if it is a survival time, you don't really have a primary endpoint. Your endpoint is death or recovery, which will have varying time frames. You can use a survival analysis. You can use a log rank test, or you can use a Cox proportional hazard model. And it is important that you should always compare the intervention arm with the control at the exit. So it is incorrect to say that the control arm improved over 12 months and the p-value is significant and the intervention arm changed this parameter over 12 months and then this is significant. No, it should not be like that. It should be comparison at exit and not between the change in baseline in the control arm and the change in from baseline in the intervention arm separately. That should never be done. Now the problem is risk ratio. Most of the time, many of the studies end with the risk ratios. The risk ratios basically is the effect size of the drug divided by the effect size of the standard of care. Let us say here we are dealing with the ESRD rates. Now rituximab, in scenario 1, the ESRD rate with rituximab is 30%, whereas standard of care is 50%. Scenario 2, the ESRD rate with rituximab is 6%, whereas standard of care is 10%. Now the ratio is 30 by 50, it's 0.6, 6 by 10, it's again 0.6. Now here there's a problem. So the difference in the first situation is pretty huge and the difference in the second situation is not that great, but we are getting the same risk ratio. And this is a problem in expressing the result as risk ratios alone. So what we need to do is we have to see how much is absolute risk reduction. In the first situation, it is point. Okay, so actually like this is actually 30 and this is 50. So it should not be 0.3, it should be 0.2. So the absolute risk reduction is 0.2, whereas here the absolute risk reduction is 4. Now we will have the number needed to treat. Sorry, this is not 3.3, this should be 5. 1 by the absolute risk reduction, that is 1 by 0.2, that is 5, which means that if you treat 5 patients, ESRD, you will prevent 1 ESRD if you treat 5 patients. The second scenario, if you treat 25 patients, you will prevent 1 ESRD. Now, a drug to be told as efficacious, the number needed to treat should be minimum. For example, you have a drug, you treat 2 patients and 1 is benefited. And if you have another drug which treats 3 patients and 1 is benefited, the one which benefits, the one which is beneficial when you treat patient is going to be the best. And on the other hand, similarly, there is something called a number needed to come. To tell that a drug is efficient, the number needed to treat should be minimal and as close to 1 if possible, and the number needed to harm should be much higher. Now, effect sizes can be expressed for continuous variables also. For example, rituximab reduce the urine protein creatinine ratio, your 24-hour urine protein excretion to 2000 milligram, and the standard of care agent reduced it to 2500 milligram. Now, with a standard deviation of 800 milligrams. So there is something called a standardized mean difference. It's basically the difference between the mean of the intervention and the control divided by the standard deviation. Here I substitute this, I'm getting a value of 0.62. This is otherwise called Cohen's d. And there are other ways of expressing depending on what your denominator is. And whatever it is, a small d is going to be, if you get this ratio as 0.2 or lower, it's small, the effect size is small. And if it is somewhere around 0.5 to 0.6, the effect size is medium, and a large effect size is more than 0.8. And unfortunately, there is no widely accepted effect size calculation thing for data which is expressed as median and interquartile range. So that's all for now. Now we will move to Arpana Madam, who will critical appraisal of the paper.
Thank you so much, Dr. Priyamvada. As always, a very clear presentation. We have related to your session. While Dr. Siddharth is getting his slides ready, I will just pull out one of those questions. So in case we have to calculate the sample size for a pilot RCT, how do we do that compared to regular RCT? So it's just a pilot RCT. So how do we calculate sample size?
Okay, let us say a hypothetical situation. We have a new drug for oxalosis. Okay, so we don't really know. We absolutely don't have data apart from that phase 2 trial on lumasiran and stiripendone and all. Okay, now you want to do a phase 3 trial. There are different ways of approaching this. Okay, I'm just assuming that you did not do any randomization in the phase 2. You are straight away going for the randomization in the phase 3 trial. So in that scenario, the best possible step would be you just go to a minimal numbers. You know that actually if you keep it 100 or 1000, you are not going to get. So let us say if you can get 20, fine, you proceed with 20, randomize those 20 and see. Now, at the end of that 20 numbers, and of course, randomized control trial is not a study method which is to be used when your outcome is very low, but still we will be dealing with certain situations. Why I come up with oxalosis is that's a disease with no definite treatment till date. Now you have a treatment, your phase 2 results were sort of encouraging. Now you're going for a phase 3. So what you want is you just recruit whatever patients possible. And sometimes you'll be able to recruit 20 patients or 30 patients. So a pilot study, the idea is to see whether this drug is safe and whether this works. And there is no hard and fast rules for pilot trials. And most of the time we'll be dealing with 20 or 30 patients at the most, or maybe 40 or like not more than that. Now, based on that results, what we can do is we can actually do a proper RCT, which we will use the results from this study for the sample size calculation.
Thank you, Dr. Priyamvada. Let's move on to the third part of the session. I invite Dr. Siddharth Herur. As I mentioned earlier, we are going to appraise the RCT paper that has been distributed earlier to this session. So let me just begin with a clinical setting that a young man, 32 years of age, hailing from a small town in Telangana, has had a past history of recurrent microscopic hematuria over 6 years. And since 1 year, he has also had proteinuria in the range of between 1 gram and 2 grams per day. He has received oral corticosteroids for about 6 months and has also been on ACE inhibitors for about 10 months. BP is well controlled with antihypertensives, and renal function is, as you see here, the eGFR is 60 ml. So a local physician has advised him to undertake treatment with rituximab. Now, he has come to a tertiary center, to Nizam's Institute of Medical Sciences, to seek a second opinion. He meets Dr. Siddharth Herur in the nephrology OPD and asks him if rituximab would help him. So, Dr. Siddharth, before going and presenting or asking advice of his HOD or head of unit, wants to do a search and look at evidence by himself. So he does a search and he gets this paper, a randomized controlled trial of in IgA nephropathy, looking at proteinuria and reduction in renal function. So next slide, please. So what we're going to do here is we are not going to deal with the objectives and the methodology, which have already been referred to during the first two sessions. We are going to the results. So what he's going to do is, I have asked him to look at the results and the conclusion of this study by looking at three important questions. The first question is, can I trust these results? So as a clinician, these three questions are very important. Can I trust the results? The second question would be, how do I understand these results? So it is difficult to understand an RCT if one is not familiar. And you've seen the various ingredients that are required to conduct this study and make a study meaningful. So how do I understand these results? And the third question would be, to whom does these results apply? Meaning, can I apply this evidence to my patient? And that's what Siddharth is going to do for us today. Siddharth, kindly take over.
Yes, ma'am. Good evening, everyone. Am I audible?
Yes, you are, Siddharth. Go ahead.
So I hope my slides are also visible on slideshow.
Yes, they are.
Yes. So as ma'am said, when this patient came to me, so I was very much excited to, to start a new drug and make the patient happy. But so when I went through the literature and saw the evidence, whether this new drug rituximab works well in IgA nephropathy, then to my surprise, I found out when I read the whole article, and I put forward the results to my head of the department. I said, the p-value is not significant. Then the head of the department said, p-value is not just enough. You should look into the results in a more elaborate manner. So that's what we are going to see now. So starting with this flow diagram, consort flow diagram, where you can see on the left hand side, on the right hand side, the follow-up period is mentioned in each of the 3 months, 6 months, and each of the sections. And there are reasons also mentioned why some subjects were discontinued, like work family reasons, gave no reason. So when I applied the same flow diagram, which is a mandatory for any good RCT, so this is the flow diagram given in the trial. So as you can see here, there are no specific reasons why there were dropouts. What was the reason for dropout? And also there was no follow-up period mentioned in the flow diagram. So all my excitement, tapered down, and I started to analyze the results more strictly. So then when I went to the baseline characteristics, this will be the first analysis of the results of an RCT. So I mean, the critical appraisal of the RCT starts from the baseline characteristics. As the previous speaker said, the baseline characteristics should be as similar as possible. So that is the prime reason why we randomize the subjects to control group and the intervention group.
So what is odd here, Siddharth, if I can interrupt? What is odd here in this table, as you rightly mentioned? What should not have been there?
Yes, ma'am. The last column of p-value should not have been there, because one school of thought is to randomize in such a way that there should not be any difference between the two groups, and the two groups should be as similar as possible. But in spite of that, due to some chance, there can be a slight difference in the baseline characteristics of the two groups.
So what are those variables here that you find that there was a difference in between the control and the rituximab group?
Here age and GFR. Ma'am. Age and
So
GFR.
kindly note, age and GFR have a p-value that is significant, and therefore it is now leading to the next step where it is a challenge now, because the whole purpose of randomization is not to have a significant difference. But here you have, and as Dr. Premvada also mentioned, that sometimes you do have, and then there are ways of handling that. So Siddharth will tell us about that. If there is a difference between the two arms, like what is shown here, then what should you consider?
So I will look for a logistic regression analysis or ANCOVA analysis to adjust for these confounding variables.
Yes, so the confounders, these should be considered as confounders. It doesn't matter what you use, but you have to identify the confounders, and then the result should include these confounders, adjustment towards these confounders. So obviously, this has happened probably because there was a small sample size. Go ahead.
Yes. So as you can see, the data are presented as median and range. That itself tells us that the data is varied and it's a small sample size and it's not normally distributed. So that point also to be noted here, because the data is presented as median and range and not as mean and standard deviation. So coming to the primary outcomes of GFR and proteinuria, which were pre-decided, and so on the left we have the rituximab group, on the right we have the control group. So as the red line suggests, there was not much change in the GFR in both the groups after the intervention and follow-up of 352 days, that is 12 months. And similar with the proteinuria, after 12 months, there was no significant difference in the proteinuria in the rituximab group as well as the control group. So these are the values mentioned in the results. Median proteinuria in the rituximab group was 2.6 gram at the baseline, with range from 0.9 to 5.3 gram. And median proteinuria in the control group was 1.8 gram. And eGFR in the rituximab group, median was 40 and the control group was 61. And the CD19 counts in the rituximab group was 84 at the start of the study. But as you can see at the end of the study, median proteinuria in the rituximab group fell down to 1.9 grams with a range of 0.4 to 8.8. But as we learn further, there was no statistical significant difference between the baseline and the end of the study. Similarly, the proteinuria in the control group, there was no statistical difference. And the median proteinuria in the control group at the baseline and at the end of the study was the same as 1.8 grams. And very important to note is eGFR in the rituximab group and the control group. Why we have posted a question mark here is because there is no data available in the entire article, even after reading for so many times. So only the baseline eGFR was mentioned, but the eGFR at the end of the study was not at all mentioned, though they have just mentioned that there is no statistical difference. So that itself is one of the flaws of this study. And CD19 counts in all the rituximab group patients went down to 0, stating that they were adequately immunosuppressed. And coming to the other disease markers and outcomes in the control versus rituximab treatment groups, as you can see here, IgA antibody levels and galactose deficient IgA1 antibodies and IgG autoantibodies all were studied as secondary subgroup analysis, but none of them showed any significant difference. But as you can see here, the number n became 10 in the secondary disease markers analysis, whereas the actual when we started, the number of people, the number of subjects in each group was 15. But coming to the biochemical markers, the data was available only for 10 patients in the either group. So which again does not support the intention to treat analysis, which was discussed extensively before.
So Siddharth, you can have, you see that there are outcomes which have been expressed in terms of numbers 3, 2, 1. So they are categorized as more than 50% and less than more than 50% with proteinuria. So these are, what type of outcomes are these?
These are dichotomous outcomes, whereas proteinuria and GFR are continuous outcomes.
Correct.
But when analyzing a continuous outcome, we will have only the effect size. But if we have to know the relative risk or the absolute risk reduction ratio or the number needed to treat, it is always recommended to dichotomize the continuous outcome and define it further.
Correct. Correct. Go ahead.
So, and this is the adverse events graph presented in the article. As you can see, they have mentioned each and every adverse effect and the number of events also, as the number of the sample size itself was very small. So they have mentioned clearly each and every side effect and also the number of patients. But what is striking is the same. I have taken this picture from the same article with underline where they have written potential intervention specific complications such as infusion related reactions and hypogammaglobulinemia. So they are also potential intervention specific complications, but they are not mentioned in the adverse effect of the rituximab group. So should we take it as no one had this adverse event, or they are not mentioned? Is of course another flaw of this study. So which I discussed with madam, and so we need to discuss it with the group here.
Yes. So Siddharth, as you rightly mentioned, this graph looks good because they're just trying to show the various side effects in the control and rituximab group per patient. But ideally, you need to have many more characteristic features mentioned if you're talking about adverse events. And that's a separate checklist given by the consort guidelines. So for example, what was the time of occurrence of these adverse effects, right? Was it after the first dose of rituximab? Was it after 6-month dose? What was the duration of events? If somebody had hypertension or headache or nausea or cough and congestion, how long did it last? What was the severity of these adverse events? Was there a statistical a difference between the adverse events reported between the arms? And was there a prior plan as to say, if there is such a side effect or an adverse effect, we will stop the drug? So these are some of the key issues that you definitely need to plan and report in every RCT. So in this particular paper, we don't have anything except one sentence which says there was no significant difference in the adverse effects between the control and the rituximab. We don't have a p-value. We don't have any figure in terms of proportion as to say this percentage was that percentage in terms of the adverse effect. So this is a major limitation of the study. Go ahead, Siddharth.
So they concluded the study with the statement that patients with IgA and relatively high risk for progressive renal dysfunction, which they defined by proteinuria greater than 1 gram persistent even after RAS inhibition. So that is the population they treated with rituximab, and they stated that it is statistically insignificant even after rituximab for 12 months. Statistically insignificant reductions in proteinuria were there, and they could not be distinguished from the response to the supportive therapy alone. So final concluding point which was mentioned in the article was it doesn't support the study doesn't support the use of rituximab for the treatment of IgA in the said population, which is proteinuria greater than 1 gram and EGFR between 30 to 90.
So Siddharth, before you go on to the appraisal part, also important to note that they could have given us details about what happens to proteinuria when they were following up these patients every 3 months. 12 months is a long period. Every 3 months, if they were following up, then we would like to know what happened to EGFR, proteinuria, because they said in methods that they were doing all these as a part of monitoring.
Yes, ma'am.
Yes, go ahead.
So, so the analysis of results, that is the understanding of the results of an RCT, doesn't stop here. In fact, it starts from here. So, so as we all know, due to varying methodological quality, the translating the results of RCT into practice is a challenge. So we can't just take every RCT seriously, and every RCT concluding point we can't just experiment on our patient, translate into practice. So that's what I'm trying to tell, because we have to assess the reliability and understand the results better, and there is a specific and systematic method to analyze how good or bad is an RCT. So this is a blueprint through which we have to read the results of the RCT and understand better before translating into clinical practice. So the first question which I want to ask myself after reading the RCT is, can I trust the results? Second is, how do I understand the results? And third question is, to whom do the results actually apply? So the first question is, can I trust the results? So as discussed earlier, so to evaluate the effect of a treatment, the best way is to compare between two groups, one undergoing treatment and the other control group. For comparison to be valid, bias has to be avoided. So a bias is anything that erroneously influences the difference between groups. So there are specific methods followed to overcome bias. So in this trial, or in any RCT for that matter, were those specific methods followed to overcome bias, and what are the different bias we know, and we have to see whether those specific methods were followed to overcome such bias. So yeah, so randomization and allocation. So this is the first step to avoid selection bias. There are many types of bias. The first step is to avoid the selection bias, through which randomization.
I think this was anyway, we did it with Nivedita's match the following also, and
Yes.
Dr. Priyambada also mentioned. So you can just say whether this particular study abided by randomization and allocation concealment.
Yes.
Why are they okay? Yes.
Yeah. So this study were the patients randomized? Yes, patients were randomized by a centrally computer generated method. But was the allocation concealed? So much we spoke about allocation concealment. How important is it? Because unless we conceal the allocation, all the effects of randomization are lost. So nothing was said about the allocation concealment in this study. So I definitely have a doubt in trusting these results, because the allocation concealment was never mentioned, and probably didn't happen. And were patients, care providers, and outcome assessors blinded? Definitely no, because patients cannot be blinded. I mean, could not have been blinded, because they received an IV infusion of rituximab, but still they could have used a placebo in the control group, and they could have blinded the patients and the care providers both. But it is an open label trial. It's not a blinded trial. So obviously there is a bias here, and outcome assessors also were not blinded. So there is a detection bias also. So only randomization was done, but allocation concealment was not done, and patients, neither care providers nor the outcome assessors were blinded, which could have been done easily by a infusion of a normal saline or some placebo to the control group. And was follow-up complete, and were the patients analyzed in the groups to which they were randomized? In other words, was it an intention to treat analysis? Yes, this was an intention to treat analysis, but it was a modified intention to treat analysis, because so the total subjects randomized to rituximab group was 17, but 14 of them completed and 2 dropouts were there. But still those 2 dropouts were included in the rituximab group. So the total subject in the rituximab group was 16. So those 2 had only one regimen of rituximab. They did not take the 6 monthly rituximab later. So only at the start of the trial they took. So 16 people were included in the intention to treat analysis. So this is something like a modified intention to treat analysis. As you can see in this, so the green color on the left hand side allocated to treatment A, before only one patient did not receive any treatment. So even if that patient also would have been included, that would have been a totally intention to treat analysis. But that patient who did not receive any treatment was excluded from the study, and therefore it became modified intention to treat analysis, which is good. And were the outcomes appropriate and reliable? Yes, the outcomes were appropriate and reliable because they can be easily reproduced. Like proteinuria and GFR are simple tests; they are universal tests, and they are very much non-invasive tests. So the outcomes were definitely appropriate and reliable. There was modified to intention to treat analysis, which because of which I trust the results. But the points where I lost trust in this trial or study was the patients or care providers and outcome assessors were not blinded, and the allocation concealment was not done. So these are the different kinds of bias. So by randomization, we are removing the selection bias. By blinding the patient and the care provider, we are removing the performance bias. By intention to treat analysis, we are removing the attrition, which is also called exclusion bias. And by outcome assessors blinding, we remove the detection bias. So any RCT, if all these biases are removed or excluded, and that means if randomization is happening and all are blinded and intention to treat analysis, that would be then I will have more trust in the results of those RCT, which was not followed definitely in this study. So my trust level has come down with this study. Yeah, as you can see, selection bias was definitely removed because of randomization, but performance bias is still there, and attrition bias was removed, but detection bias is still there. Yes, ma'am. So with regarding to the first question of how can I trust the results, the initial part of excitement came down after critical appraisal, and when I saw that there is bias which was not excluded, so I do not trust the results.
The editor of CJSN should not listen to you.
Okay. So basically what I want to that's why. Yes. Basically what I'm trying to say is the trust with which the results came down by 50%.
Okay, go to the next question. How do you understand the results? You have about 5 minutes, Siddharth. So
yes. So how do I understand the results? So I need to know about two things, which are estimation of treatment effect and precision of estimation. So these are not just English sentences. These are specific terminologies which we need to understand. So estimation of treatment effect is the magnitude of the effect. It is not the p-value. P-value alone gives no information on the magnitude of the effect. It is the contrast between two groups. I mean, how superior is the drug which we have put in the intervention group compared to the standard group. So that is the magnitude of the effect. So we need to know the magnitude of the effect before we apply to the patient. So as I said here, the clinical trials must determine more than simply whether the treatment has an effect. It should determine if a treatment has a big enough effect to be clinically worthwhile. So statistical significance and clinical significance are two different things. So we should not just stop at the statistical significance. We should even know about the clinical significance. So as we discussed, there are two types of outcomes: dichotomous outcome and continuous outcome. So dichotomous
outcome. Give an example of dichotomous and continuous.
Yes, ma'am. So dichotomous is like in our trial, whether they have achieved 50% reduction in proteinuria or not, like whether they have achieved complete remission or not. So it's an event, yes or no, just like survival, whether you after intervening with the drug, whether you have lived or died. So that is a dichotomous outcome. In nephrology, like basically partial remission or complete remission, or whether they have ended up in ESKD or not. So those are simple examples of dichotomous outcomes. And continuous outcomes are proteinuria and GFR who have continuous numbers. So with respect to dichotomous outcome, we have specific estimation of treatment effect, which can be estimated by risk ratio or risk difference, absolute risk reduction. And so absolute risk reduction tells us the expected absolute benefit when between the two groups, or number needed to treat, NNT, which is the reciprocal of absolute risk reduction. So that tells us the number needed to treat with the new treatment for one additional patient to get benefit. So with which I can explain the patient, how good that new treatment is. So with respect to continuous outcome, so the difference in means, which is known as the effect size, which is mean treatment minus mean control by standard deviation of pooled groups. This tells us about the magnitude of the treatment effect, and 0.5 is a medium effect and 0.8 is a large effect size. So and when we have a continuous outcome, if we translate into dichotomous results, the results will be more meaningful. For example, I have taken a small example where 100 subjects are there in each group, and we have added a new drug to see whether it is helpful or not. But 20 died in the control group and 15 died in the intervention group. So definitely there is some mortality benefit in the intervention group. That's what we thought. Then relative risk, if we see, it is a simple mathematics. 15% by 20%, that comes to 75%. That means the new treatment reduced the risk of death by 25%. So this is the relative risk. And absolute risk reduction is just the difference, and it turns out to be 5%. So that means the new treatment which we are planning to execute, it has only 5% of benefit. And if we calculate further and calculate a number needed to treat, that is NNT, which is the reciprocal of absolute risk reduction, we get a 20. So that means if we treat 20 patients, then we will prevent one death. So which is a good number. So
the smaller the NNT, the better.
Better, yes.
Right? And all these are not really applicable to this paper. Why? What is the reason, Siddharth?
Because the outcomes are continuous and not dichotomous.
Okay, and
also the data presented is in the median and range. Data is presented as median and range and not as mean and standard deviation.
Right. Go ahead.
So whatever we have learned till now, that the relative risk and the absolute risk reduction and the number needed to treat, they are all point estimates, but we need to know how precise that estimate is. So that we have estimated till now the RR, ARR and NNT, and we need to further know how precise the estimate is, for which we need to know the confidence interval. Confidence interval we usually measure by 95 or 99%, but most probably in most of the RCTs it is 95%. It tells us the width or range that includes the true value of the effect 95% of the time. So the larger the sample size of a trial, the larger the number of outcome and events, so greater our confidence that the true RR is so close to what we have observed. So with respect to this trial, so the estimation of treatment effect for continuous or dichotomous outcomes, it was not mentioned, as well as the precision of estimation also was not clear. So coming to the last question, which is to whom do the results apply? So we need to see we need to see three parameters: whether the results are externally valid, and what are the adverse effects profile, and whether there was any conflict of interest. So external validity, setting of the trial and the patient in front of you. So we need to see, if the setting of the trial patient is an Caucasian, but well-built Caucasian, and the patient in front of me is a very lean, malnourished Asian with the same parameters. Definitely, I need to rethink my decision to treat the patient with the drug. So we need to see what was the population of the trial and what is the patient in front of you, and the ratio of randomized patients to eligible non-randomized patients, and the difference between trial protocol and routine practice, and outcome measures and follow-up. As we learned about number needed to treat, we need to have a number needed to harm also. So because secondary outcomes in any RCTs will be safety. So after efficacy, safety is also very important. So a number needed to harm is nothing but 1 by proportion of adverse events in treatment group minus control group. So we will get a number needed to harm. So more the number needed to harm, safer the drug. It's the vice versa of less the NNT, better the drug. So more the NNH, safer the drug. So basically any RCT should have, we should be able to calculate the number needed to treat and number needed to harm to know the effect of, to know the magnitude of the effect of the new drug. And coming to conflicts of interest, so we should read the trial in such a way that at the end of the trial, we should be knowing, were there any conflict of interest?
So were that mentioned here in this paper?
No, ma'am, no.
In the end of the paper, Siddharth, there are acknowledgements and there are also conflict of interest declaration, which clearly mentions though Roche had supported this. So there was an industrial support, but they had nothing to do with the study protocol or the data analysis or the results. So this also needs to be looked at before you decide to apply the results to. We're not saying industry support is bad, but we have to look at it in a particular context when you decide to apply the results to your patient. So I go to the next slide, and that will be the last slide that Siddharth has looked at the consort guidelines, which is available on Equator Network. These are standard guidelines that give us the various domains that need to be reported for every RCT. So just run through that so that people will know how many questions and how it is reported. Next slide, please.
Yeah.
Yes. So these are, it starts from the title, goes to the introduction, background, objectives, methods, results, and we need to go through each of these checklist items when you report. So it's mainly for reporting, but even if you have to appraise, it's good to look at this because then you will not miss out on the finer points when you have to actually look at how well the RCT was conducted. Do you want to conclude, Siddharth, with your last practical points?
Yes, ma'am. So, so the randomization and the allocation concealment should be clearly mentioned in the trial, and blinding obviously is the best way to avoid performance and detection bias, and whether blinding was done and who was blinded should be clearly mentioned. As Dr. Nivedita said, now the terminologies of single blind, double blind, and triple blind are extinct, and now so we need to clearly mention who are blinded, and that tells us which bias was excluded. And when it is obvious that, except that when it is obvious everyone is blinded. And intention to treat analysis is definitely the most robust analytical method, so we should look for it whether the trial had intention to treat or per protocol analysis. And the primary outcome must be unique, be clinically relevant, and be available for all patients, and have a good reliability and reproducibility. And also steady results should report both a measure of the treatment effect, like relative risk or absolute risk reduction or effect size or number needed to treat, and also the estimation of the precision of this measure by confidence intervals. And all the readers, we as readers need to critically appraise the statistical and clinical significance of a result before we take the RCT seriously and start practicing based on that.
Excellent, Siddharth. Very confident and informative presentation. I'm very, very happy that you learned a lot, because compared to the first time we met and you made your slides and to what you have now presented, it's very evident. Significant p-value that your understanding of RCT is much, much better than before. And this is the first step. Once you understand this, now you can definitely look at many more RCTs now with much more ease and comfort, and you're not overwhelmed with reading an RCT and understanding the results. The finer points also, you have put in efforts to understand them. So well done. There are some questions. The first one question is, in LMIC, should we encourage pragmatic RCT rather than blind RCT? Will pragmatic RCT be a equally strong evidence for guideline framing. I would direct this to Dr. Priyambada.
Yeah, am I audible?
Yes, yes, please do.
Yeah, so basically we should not confuse between blinding and pragmatic RCTs. So pragmatic RCTs basically, it just stays close to the clinical practice and we can very well do the blinding also. Blinding is not a difficult task because especially with an oral drug and all, there are many pharma companies which actually will give you the placebo agent. So if you do an RCT, it is always better to be blinded, especially like if, see, for example, sometimes we'll be focusing on the safety aspect also. A drug might be effective, but problem is like, let us say 60% of the people who receive the drug are complaining of GI adverse effects. We don't really know whether it is actually a real effect, and that we will know only with placebo. So it is pragmatic RCTs are of course useful, and most of the time the regulatory trials have a very strict setting. So which probably may not be reproduced in the real life setting. For example, let us say we find that probably there is a 20% reduction in ESRD or adverse renal outcomes with a particular drug. When we actually give in day-to-day clinical practice, we will always see that the effect is not 20%, it is going to be 10%. That possibly happens from the rigid atmosphere of a regulatory trial. And of course, we should focus more on pragmatic trials. And see, they are not actually, they cannot replace one another. Of course, we need regulatory trials for the development of newer drugs. And there's nothing preventing you from introducing a placebo in a pragmatic trial. If possible, do that. Otherwise, let it be an open label, but we should be aware of the biases involved. We need regulatory trials because otherwise no molecules are going to come.
Thank you, Dr. Priyambada. We don't have any more questions. So let me take this opportunity. Oh, there's one coming up again. If we have the time, I can read out that. 1 minute. So in India, clinical trials are registered under CDSCO, DGCI. The labels differ in clinicaltrials.gov. Our Indian trials also registered under clinicaltrials.gov as data is always based on clinicaltrials.gov.
So basically, like CDSCO is dealing with the regulatory trials. For example, you want to start a new molecule, you have to get a CDSCO registration as well as a CTRI registration. For example, something which is marketed, and for example, you want to use rituximab in IgA nephropathy, you don't really need a CDSCO approval. What you need is only a CTRI approval. Regulatory trial, in addition to CTRI approval, is mandatory for all trials. But for regulatory trials, in addition to CTRI approval, you need a CDSCO and a DCGI approval as well.
Thank you. With that, we come to the end of this session. Thank you for being with us for 2 hours. It's a long stretch. And congrats to all the 3 residents for taking time out despite your regular duties and responsibilities, and for joining us in understanding all about RCTs. Thank you, Nivedita. Thank you, Dr. Priyambada. Thank you, Win Leeds, for giving us this opportunity. I think we may look at systematic reviews 3 months from now. If there is a demand for any other topic, kindly reach out to us. Otherwise, we will get back and see you again after 3 months. Thank you so much.
So thank you all.